Hello and welcome. Today we're diving into a really critical tool that is seriously changing the game in patient care. It's called myocardial strain. Think of it as a powerful new way to get ahead of one of the toughest side effects of cancer treatment, cardiotoxicity. So let's unpack the evidence and see exactly how this fits into your day-to-day clinical practice. This really gets to the heart of the matter, doesn't it? Here you are, using these incredibly powerful, life-saving therapies to fight cancer. But what if those exact same treatments are causing unseen and maybe even irreversible damage to the heart? It's a massive balancing act that really every oncologist has to face every single day. And there's a name for this: cancer therapeutics-related cardiac dysfunction, or CTRCD for short. We know that workhorse drugs like anthracyclines and trastuzumab are amazing against cancer, but they can be pretty rough on the heart muscle. The real challenge has always been, how do we spot this damage early enough to actually do something about it? So, how have we traditionally kept tabs on the heart? Well, for decades, the answer has been one specific measurement. But as we're about to see, this old watchdog, well, it has some pretty serious blind spots. And that measurement is, of course, left ventricular ejection fraction, or LVEF. It's a pretty simple concept, right? It just measures the pumping efficiency of the heart's main chamber. And for a long time, it's been the absolute cornerstone of cardiac assessment everywhere, including oncology.
But here is the massive problem. LVEF is a late indicator. It's kind of like a smoke alarm that only goes off after the fire is already raging. By the time you actually see a meaningful drop in LVEF, that underlying injury to the heart muscle has probably already happened, which makes a full recovery way harder. It's also famously variable and can look deceptively normal, even while the heart muscle itself is getting weaker.
Okay, so if LVEF isn't sensitive enough to give us that early heads up, what is? Well, let's take a look at a completely different approach, one that gives us a much earlier and, frankly, a much clearer picture of what's happening to the heart muscle itself.
And that brings us to myocardial strain, specifically global longitudinal strain, or GLS. Now, this is measured with a technique called speckle tracking echocardiography. It doesn't just look at how much blood gets pumped out. Nope. Instead, it measures the fundamental function of the heart, the actual squeezing and shortening of the muscle fibers. It's a direct look at the health of the myocardium.
And this right here, this image, shows you exactly why GLS is so much more sensitive. See the innermost layer of the heart muscle? The subendocardium is packed with muscle fibers that run lengthwise from the bottom of the heart to the top. This layer just happens to be the most vulnerable to damage from things like chemotherapy. And it's the function of these specific fibers that global longitudinal strain measures.
The evidence on this is just crystal clear. As this quote spells out, when you have a problem with these longitudinal fibers, which GLS picks up, that's an early warning sign. It shows up long before the overall pumping function, the LVEF, starts to tank. You're basically catching the problem right at the source.
Let's put them side by side. LVEF measures pumping efficiency. GLS measures the health of the muscle. LVEF is a late indicator, GLS is an early warning system. And this is huge. GLS is much more reproducible, which makes it a way more reliable tool for tracking changes over time. It doesn't just tell you about damage that's already happened, it helps you predict future problems. Okay, so that's the science. But the big question is, how does this actually lead to better patient care? Let's walk through how you can use GLS at every single stage of a cancer patient's journey.
This is the key. GLS isn't just a one-off test. It's a whole surveillance strategy. It gives you actionable information before, during, and long after cancer therapy is done, helping you make smarter decisions every step of the way.
We can really just break this down into 3 simple stages. First, you're assessing risk before you even start. Second, you're monitoring for early damage during treatment. And third, you're conducting surveillance for any late effects in survivorship.
So, stage 1. Before a single dose of chemo is given, a baseline GLS can flag patients who are at higher risk. In fact, studies are showing that a subtly abnormal GLS at baseline is a much stronger predictor of future heart failure than a low normal LVEF is. This lets you decide who needs closer monitoring or maybe even some preemptive strategies.
Now, during therapy, this is the number you need to burn into your brain: 15%. A relative worsening, a drop in GLS by 15% from that baseline, is the accepted clinical threshold. That's your signal. That's the alarm bell telling you subclinical cardiotoxicity is happening, and it's time to think about intervening. And that 15% change is your early warning. It can pop up months,
literally months, before the LVEF even budges. This opens up a critical window of opportunity to start cardioprotective drugs like ACE inhibitors or beta blockers. This proactive approach can prevent long-term damage, and, this is so important, it can help you keep your patient on their optimal cancer therapy without interruptions.
And we have really solid evidence that this strategy works. The SAKUR MRI trial was a huge landmark study. It showed that when doctors started cardioprotective therapy based on a drop in GLS alone, their patients had significantly less decline in their LVEF down the road. Acting on GLS just flat out leads to better outcomes.
And this slide shows you exactly what we're talking about. These are called bullseye plots. On the left, you see all that red. That means healthy uniform contraction. The GLS is negative 14.9%. Now look at the right. The colors are all over the place, and the strain is much worse at negative 7%. With GLS, remember, a less negative number is actually worse. The plot on the left is that early warning, giving you a chance to step in before the heart looks like the plot on the right. Now think about what this means for long-term survivors. The St. Jude Lifetime Cohort Study, an incredible project, looked at adult survivors of childhood cancer. And what they found was staggering. 28% of survivors who had a completely normal LVF had cardiac dysfunction that was only picked up by GLS. We are missing a ton of heart damage by just relying on LVF. And that's exactly why stage 3 is so vital. The risk doesn't just stop when the treatment ends. Cardiotoxicity can show up years, even decades later. GLS is the essential tool we need for long-term surveillance in our growing population of cancer survivors. It lets us catch that late-onset dysfunction that LVF would completely miss. So when you put all of this together, the evidence really points to a clear shift in how we need to think about watching the heart in oncology. We've got to move from being reactive to being proactive.
So, what are the key takeaways for your practice? It's pretty simple. First, think of GLS as your early warning system. Second, use that 15% relative drop as your clear, evidence-based signal to take action. And third, integrate GLS into all 3 stages of care, before, during, and after therapy.
And look, this isn't just some newfangled idea. It is rapidly becoming the standard of care. The incredibly influential 2022 European Society of Cardiology guidelines on cardio-oncology now officially recommend measuring GLS in all cancer patients getting an echo, whenever it's available. The consensus is here.
Which really just leaves us with one final question. With its power to predict risk, detect injury earlier, and guide therapy to improve outcomes, isn't it time we make global longitudinal strain the new vital sign for every single patient undergoing cancer therapy? When you look at the evidence, the answer seems pretty clear.